Well, hello. This is a continuation of Chapter 7. We will be talking today about the pelvis and the hip. When we start off in Chapter 7 on page 264, we had looked at this before when we discussed femur. But when we look at the parts of a proximal femur, we actually have the head of the femur that sits in the acetabulum of the pelvis, and this forms the hip joint between the head of the femur and then the cup-shaped depression called the acetabulum on the pelvis. We have the neck of the femur, the greater trochanter, and the lesser trochanter, and this is looking at it from the anterior view. And when you turn it around and look from the backside or posteriorly, you've got the greater trochanter, which sits laterally, and the lesser trochanter, and then you've got the intertrochanteric crest that runs between the two. And then we have the body or the shaft of the femur. When we look at the pelvis, this is found on page 265. And the pelvis actually consists of 4 bones. There are 2 hip bones, which the hip bones in here are kind of this gray. You have 1 hip bone, 2 hip bones. Now those hip bones can be called innominate bones or ossicoxy. So you have 2 hip bones, and then you also have the sacrum and the coccyx. So when you talk about the pelvis as a whole, it's the sacrum, which this is in green, the coccyx, which is in kind of like a purple, and then the 2 hip bones, which are this gray right here. Now, the hip bones, or the innominate bones, consist of an ilium, an ischium, and a pubic bone. Okay, so you have the ilium, which is the wing of the pelvis, the ischium, which makes up the inferior portion of the pelvis, and then the pubis, which makes up the anterior portion. Okay, so each hip bone consists of an ilium, an ischium, and a pubis. And it says that in a child, those bones are actually separate, but they fuse into one bone during the middle teenage years. And it says the fusion takes place in the area of the acetabulum, which is this deep cup-shaped depression that accepts the head of the femur and actually forms the hip joint. So the 3 join in the acetabulum, and that's what actually makes up your hip joint. The ilium is the largest of the 3 bones, and it is the most superior. The ischium is the most inferior and posterior. And then the pubic bone is inferior but anterior as well. Okay, so 2 hip bones, a sacrum, and a coccyx make up the pelvis. If we look at that in more detail, again with the different colorations here, you've got the ilium, which is the wing or the body of the pelvis. You've got the ischium, which sits inferior and actually posterior. When you look here from front to back, you can see how the ischium is more the posterior aspect of the hip bone. And then you've got the pubic bone right here, which sits not only inferior to the ilium, but also sits the most anterior. And then all 3, you can see the different color markings on here, form this cup-shaped depression, which is the acetabulum. If we look at the ilium in a little bit better detail, the top of the ilium is the iliac crest, which is a significant landmark for us to use when we're positioning for abdomen. A lot of our positioning, we actually use the iliac crest and either go at the level of the crest or above the level of the crest, or just as a good guide to let us know where in the abdomen we are. We have the ASIS, which is the anterior superior iliac spine, and that was cut off a little bit, but it should say anterior superior iliac spine. So your ASIS is anterior, and that's when the patient lies on their back, those 2 little prominent protuberances that stick out on the front of the ilium. Okay, those are the most common. The iliac crest and the ACES are our two landmarks that we tend to use quite a bit in positioning. We also have, this is the ala or the wing of the ilium. And then you also have a posterior superior iliac spine as well. Not that we really utilize that for much of anything. We typically use iliac crest and the ACES. And again, this is anterior, this is posterior, looking at it from the side. If we look at the ischium, we can see that the ischium is this purple. You've got the ischial tuberosity. This is the area in your backside or in your buttocks when you sit on like a bleacher seat or a really hard seat, and the next day kind of sore, kind of hurts from your bones digging into the bleacher or into the hard seat. It's actually your ischial tuberosity that is doing that. Okay, so again, there's a lot of anatomy on the ischial spine, the sciatic notch, the ischial tuberosity, and the ramus of the ischium, but not that they do reference this as a palpable landmark for a PA abdomen. And then the last of the three bones that make up the hip bone, we have the pubic bone or the pubis. And this, we said, makes up the inferior portion and also the most anterior portion. And where the two pubic bones come together, that actually forms the pubic symphysis or symphysis pubis. Either way is acceptable. Pubic symphysis is typically how you hear me refer to it, but symphysis pubis is also correct. So where you have the left and right pubic bones come together and form that union in the front. Again, we tend to use pubic symphysis as a landmark also for abdomen. It correlates to the inferior portion of the abdomen. And then we have the obturator foramen. The obturator foramen, again, all three of the bones, the ilium, the ischium, and the pubic bone, form the acetabulum, which accepts the hip joint. And another significant thing in the pelvis is the obturator foramen. That is the large opening formed by the ramus and the body of each ischium and the pubic bone. It is the largest foramen or the largest hole in the human skeletal system. So the obturator foramen. Okay. Obturator foramen, largest hole in the skeletal system, formed by the ramus and the body of each ischium and the pubic bone as well. As far as the landmarks of the pelvis, we discussed that we use the crest of the ilium or the iliac crest, and we also use the anterior superior iliac spine. So again, looking at it from the front and from the side, you've got the crest of the ilium. People say they're putting their hands on their hips. They're truly not putting their hands on their hips. They're actually putting their hands on the iliac crest. And then we have the anterior superior iliac spine, which is also a positioning landmark that we use. We've got the ischial tuberosities, the pubic symphysis, and the greater trochanter, which sits in the lateral aspect of the femur. All bony landmarks that can be utilized for positioning. If we look at the birth canal, the main thing that I wanted to point out with this is that we have a pelvic inlet, which is represented by the dotted lines here, and then we also have the pelvic outlet. Okay, you can see the baby forming in the mother's womb, and then this would be the direction of the birth canal. And we have the pelvic inlet and the pelvic outlet. Okay. We talk about the oblique plane defined by the brim of the pelvis, right here, is referred to as the pelvic inlet. And then the outlet of the true pelvis is defined by the two ischial tuberosities and the tip of the coccyx. So this is the pelvic outlet. Now, why did I want to point that out? We used to do what was called cephalopelvimetry. we used to use a special ruler called a Coulter-Sussman ruler, and it would be placed next to the pelvis for an AP and a lateral projection on a pregnant mother just prior to giving birth. What they would do is we would take these images and measure the baby's head. And what we would do is, along with measuring the inlet and the outlet of the pelvis, so we would measure the inlet, the outlet of the pelvis, and then measure the baby's head circumference, all with that Coulter-Sussman ruler. And what we would do is they would pretty much decide if the woman was going to be able to have the baby naturally or if they were going to have to perform a C-section. All right, but typically now, because of the radiation involved, this can usually be determined by doing a sonogram. Since there's no ionizing radiation with a sonogram, that is the preferred route. So you probably would never see that cephalophotometry done. But just to point it out, there are also views that we can do to demonstrate the pelvic inlet and the pelvic outlet. Okay, but typically it was done to measure the woman's inlet and outlet, measure the baby's circumference of the baby's head, and decide if the baby was going to be born naturally or would need a C-section. When we look at some of the differences between genders of the pelvis, this is on page 268. Typically the three differences are the general shape of the pelvis, the angle of the pubic arch, and the shape of the inlet. So you can see up here we have a female pelvis, and down here we have a male pelvis. They tell us on a male pelvis, the general shape of the male pelvis tends to be narrower, less flared on a male. The wings or the ilium, the ala, are less flared. The angle of the pubic arch tends to be more acute or less than 90 degrees when we look at the angle of that. The angle is measured by the inferior rami of the pubis. Okay, so you're looking right here, the angle of this tends to be more acute in a male versus a female. And the shape of the inlet, we talked about the angle of the pubic arch and then the general shape. When we look at the shape of the inlet, typically, again, it's narrower. The male pelvis tends to have an oval or a heart shape to it compared to the female. The female pelvis, typically we have a very large or round inlet. The angle down here is much more obtuse, greater than 90 degrees on a female. Okay, so, and the wings of the ilium tend to flare out much more. I'm sure you've heard someone use the term she has birthing hips, because female pelvises tend to be much wider, much more flared out than a male pelvis. If we look at this radiographically, you can see that the female pelvis tends to be, the ilium are much more flared out, like they lay down and they're flatter. Compared to the male, you can tell these are actually coming up more than a female pelvis. The inlet is very large and more round compared to the male, which is more like a little oval shape. And then again, the angle, this angle right here, much more obtuse compared to this angle, and that's a gonadal shield. So if I try and use that to draw the angle that they're looking at, they're talking about here. Let me try that again. Much wider angle right here. Sorry. One more time, third time's a charm. When you look at this angle compared to the angle right here, this one is much more obtuse, greater than 90 degrees, probably less than 90 degrees, right? And again, this is a shield that is placed over the testicles to shield the gonads. So inlet tends to be greater, wings flared out more, large inlet, more round shaped compared to an oval or heart shape, and less flaring on the wings. When we look at the anatomy on an AP pelvis, again, if we look just to guess, this is a female pelvis. You can see the iliac crest, which is represented by the most superior portion of the ilium. You've got the ASIS, or the anterior superior iliac spine. The body of the ischium down here, ischial tuberosity right here. This would actually be the left ischial tuberosity, the body of the left ischium. You've got the pubic symphysis right here where the two pubic bones join together, so that space is actually pubic symphysis. You've got the inferior ramus of the right pubic bone for G. I'm sorry, the inferior ramus of the right pubic bone is F. The superior ramus is actually G of the right pubic bone. H is the right ischial spine. I, this right here, this cup-shaped depression right here, is the acetabulum. And that, again, accepts the head of the femur. So I is the acetabulum. K is the greater trochanter right here. L is the head of the right femur, sitting in the acetabulum, forming that hip joint. And then M is the ala, or the wing of the right ilium. Okay, you can see right here, coccyx, and then sacrum, coming all the way up. Got the sacrum, and then the little smaller segment right at the bottom, which is the coccyx. You've got right femur, left femur. You can make out greater trochanter, lesser trochanter right there. Okay. Obturator foramen, the big holes right here. So all of that anatomy on the pelvis. Now, just to review, when we talked about an AP proximal femur, we talked about being able to localize the femoral neck. And this is on page 271. Not sure why that arrow is there. Should not be placed there. So we'll just kind of X that out and we'll fix that. So don't pay attention to that arrow. Probably should have been drawn here to reference that this is the method we actually use to localize the femoral neck. So you find ASIS and you go 1 to 2 inches medial from the ASIS, and then 3 to 4 inches down. And that should put you right at the femoral neck. Okay, so find ASIS, 1 to 2 inches medial from the ASIS, 3 to 4 inches down should put you at the femoral neck. And if we look radiographically, again, 1 to 2 inches medial from the ASIS, 3 to 4 inches down from ASIS, put you at the femoral neck. Because remember, what we try to do when we internally rotate the legs is to make the femoral neck parallel to the IR. And in order to do that, we have to internally rotate the legs because of the degree of angle of the femur in relation to the floor. When we stand up and the way our legs are built, you have to internally rotate those legs in order to get the femoral neck parallel to the IR. When we look at the body in anatomic position, now, what do I mean by that? I mean with the feet. Hang on one second. When the feet are like this, where they're in anatomic position, meaning feet forward like this, remember, when their feet are like this, the lesser trochanters are definitely visible. Okay, so when we have anatomic position with the feet like that, what you're getting is a true AP of the knee, the leg, and the ankle. So your knee, your tib fib, and your ankle are going to be AP, but your hip will not. again, because of this angle, you will not be completely AP with the hip joint. So with the feet straight up in anatomic position, like on page 212, oops, the feet straight up in anatomic position, what happens is that the lesser trochanters are definitely visible. Right here, they're kind of pointed out because the femoral necks are not parallel to the IR. So you can barely make out greater trochanters because it's kind of too dark, but definitely you can visualize lesser trochanters, which is not what we want on the proximal portion of the femur or the hip joint. Okay. Remember, it's also, we talked about shielding, that it is possible to shield a male patient, but typically we do not shield a female patient. So if we start with looking at the pelvis, the routine position for a pelvis is typically just an AP pelvis. And this is going to be found on page 279. All right. And routine pelvis would just be an AP, but we will talk about a bilateral laterals called a modified cleaves, but that is only done on children. So if you look at your cheat sheet, you'll see where it says pelvis, and it says an AP of the pelvis, and then underneath it says bilateral modified cleaves done only on children. So when we look at the AP pelvis on page 279, now again, this is done if it's a non-trauma patient, meaning if that patient presents with one leg flopped out to the side or screaming and writhing in agony, we are not going to internally rotate the limbs 15 to 20 degrees, okay? If they are able to, then we would prefer to rotate their limbs 15 to 20 degrees internally, because what that would do is place the femoral neck parallel to the IR, okay? We're on a 14 by 17 crosswise or landscape. Our technique is going to be 80 kVp at 12.5. Remember, that was the same technique we used for femur. And just to let you know, it's going to be the same for femur, hip, and pelvis, all the same exact technique. 80 kVp at 12.5 mass. Okay, so we internally rotate the legs 15 to 20 degrees, kind of point the toes together. This will make the femoral necks parallel to the IR. And you also want to make sure that the patient is laying flat. How do we do that? We palpate their ACEs on both sides and make sure that the distance between your hand or their ACEs and the tabletop is equal. So you make sure the pelvis is not rotated by palpating the distance from ACEs to tabletop, and make sure that they are equal. You want to internally rotate the legs 15 to 20 degrees, just kind of point their toes together. And the central ray is perpendicular to the IR, midway between the level of the ACEs and the symphysis pubis. And this is approximately 2 inches below ACEs. So you're going to find ACEs. Now, I don't know where her ACE is. We'll probably guess right about there. So you're going to be 2 inches below ACE and then midline. Okay, 2 inches below ACEs and midline, 80 kVp, 12.5 mass. Now, if this is done correctly, ideally the lesser trochanters will be barely visible because you've internally rotated the legs. Okay, you can see right about here is ACEs, so about 2 inches down, and then midline. So central ray was probably right about here. You need to include the entire pelvis, so all including the iliac crest beyond the ischial tuberosities. You do need some of the proximal femur. Ideally, you include at least the greater and the lesser trochanter, and in theory, you go a little bit beyond that. Looking at the wings of the pelvis, it does not look like there was any rotation for the patient. Looking at the obturator foramen, they seem equidistant, One's not foreshortened and the other one's not elongated, which all indicates that the patient was likely not rotated when this was made. Okay, central ray 2 inches below ACES and midline, 80 kVp at 12.5 mass, and that'd be your AP pelvis. Now, the bilateral frog leg that we talked about, or the modified cleaves, this is on page 280, and this is called AP bilateral frog leg, or a modified cleaves position. Now, this is done to evaluate DDH or CHD in a child. What is that? DDH is developmental dysplasia of the hip. DDH, developmental dysplasia of the hip. And the older term that it used to be called was CHD, or congenital hip dislocation. Now, remember, congenital means born with. So a congenital hip dislocation is where the child is born with dislocated hip or hips. And a lot of times they'll actually have to do follow-up studies on that child where they do these bilateral frog leg. Again, you're on a 14/17 crosswise. Make sure the pelvis is not rotated, checking ACES to tabletop. And you typically abduct the femurs 40 to 45 degrees from vertical. And central ray is approximately 3 inches below ACES and midline. All right, 3 inches below ACES and midline. Now again, this would not be an adult. If we were doing this, it would be a child, and we'd be evaluating for developmental dysplasia of the hip or a congenital hip dislocation. And notice how they do have her shielded. And if you were doing this for the hips for DDH or CHD, it would be appropriate to shield both males and females, because all they're typically concerned with when they're doing this is the hip joints themselves. So ovaries could be covered, testicles could be covered. That's not going to obscure any anatomy when they're looking at the acetabulum and the head of the femur. Looking at this information right here, this is not going to take away from that. Okay, you need to be able to visualize the femoral heads and necks, the acetabulum of both hips on one radiograph, right? And that is called a modified cleaves, bilateral modified cleaves, done on children when you're trying to evaluate or demonstrate congenital hip dysplasia or developmental dysplasia of the hip. And that is all there is to a pelvis, either typically an AP pelvis, or if it's a child and they're evaluating that, it might likely be an AP pelvis along with a modified cleaves or a bilateral frog leg. Again, the bilateral frog leg is not done on adults. Then we move on to the hip. And if we look at the hip, the routine positions for a hip are some facilities protocol include an AP pelvis, an AP unilaterally of the hip, so an AP of the affected hip, and then a lateral hip. Now, some facilities only want the AP unilateral hip and a lateral, but more and more, especially the Advent Healths, they are starting to request an AP pelvis along with the hip exams so that they can evaluate or at least visualize the non-injured hip along with the injured hip. So if you injured your right hip, it could be that we do an AP pelvis showing both, then an AP of the right hip and a lateral of the right hip. And if it's trauma, ideally what they'll do is just an AP pelvis to include both, and then the Danelius-Miller shot. When we look at the routine hip, assuming that they want the AP pelvis, again, this is found on page 279. Patient lays flat on their back, You palpate ACEs to tabletop. Make sure they're not rotated. Internally rotate their lower legs. Sometimes we'll call this pigeon toeing the patient. That makes the femoral necks parallel to the IR. Our technique is 80 kVp at 12.5 mass. And you are collimated or utilizing a 14:17 crosswise for these images. Central ray is midway between the level of the ACES and the pubic symphysis, which is approximately 2 inches below ACES and midline. Okay, so they could request an AP pelvis. And that image would look like this, where again, you're evaluating the entire pelvis. You're getting the proximal portions of the femur. The lesser trochanters ideally are not visible or barely visible. Then do an AP of the unilateral or the affected hip, and this is on page 285. And you'll notice this is exactly like the AP of the proximal femur, which makes sense because the proximal femur is what makes up the hip. So this is the exact same image that we would do if we had to do the femur for the proximal femur. Okay, collimate to about a 10:12 lengthwise. Your technique is still the same as it is for all of this entire chapter. 80 kVp at 12.5 mass. You're going to internally rotate the affected leg 15 to 20 degrees to make the femoral neck parallel to the IR. And we're going to utilize that positioning to figure out where the femoral neck is by going 1 to 2 inches medial and 3 to 4 inches distal from ACES. And if we go back and check out what we're talking about with that, it would actually be this, where you're finding ACES 1 to 2 inches medial, 3 to 4 inches down, and that will put you on the femoral neck. And if the foot is internally rotated, then what that will do is actually make the femoral neck parallel to the IR. And then graphically, this image would look like this right here, where you have the proximal 1/3 of the femur included. You visualize the hip joint and the acetabulum. So you've got the femoral head and then the acetabulum as well. You want to visualize all of that. Lesser trochanters either not visible like they are here or barely visible. If there was a prosthetic, the entire thing would have to be included. Since there is no prosthesis, this is actually a good image of an AP unilateral hip. Nice exposure factors. Again, you can visualize soft tissue, bone trabeculi, trabecular patterns in the bone. I would guess this is an older patient, as there is some mineral loss in the bone, not as bright white as we might anticipate. Okay, so that is an AP of the unilateral hip. And then we would also do a lateral of the affected hip, and this is found on page 287. Okay, this is also called a modified cleaves, but remember, this is unilateral, meaning you're only doing one hip. When we were talking about the child, that was also a modified cleaves, but that was bilateral hips when you're looking for developmental dysplasia of the hip or congenital hip dysplasia. So the unilateral frog leg, or the lateral of the hip, on page 287, you're basically going to abduct the femur about 45 degrees from vertical. Okay, this one right here. You're going to place some kind of sponge underneath the patient to help them hold that up. And the central ray is perpendicular to the femoral neck. So again, you're 1 to 2 inches medial from ACES, 3 to 4 inches down. And graphically, that would look like this, where you're getting the entire femoral head, the neck, and the trochanters. All right, just a really good visualization of, again, all of that anatomy, which this looks to be the same patient that they did in the AP, again, with the loss of mineral, loss of calcium in the bone. But this is a unilateral frog leg or a modified cleaves. Okay, so that was a routine hip, which might include an AP pelvis, an AP of the affected hip, and a lateral of the affected hip. If we do a trauma hip, that would include an AP pelvis without internally rotating the legs, and then a Denalius Miller. So if you look at a trauma AP pelvis, you do not rotate the legs internally like they have here. This is only done for non-trauma. Okay, so you would basically just leave the legs as the patient presented. Your central ray would be midway between the level of the ACES and the pubic symphysis. Okay, just like the image on page 279. Okay, so you're about 2 inches below ACES and midline. No internally rotating the feet, though, because this would be a trauma pelvis. So you're just taking the AP pelvis to see what's going on with the patient. When you evaluate that, you're probably going to be able to visualize the lesser trochanters, because when you're not internally rotating the legs, these are going to be more visible than they would if you were able to. But again, it's a trauma hip. Okay, so entire pelvis, you want to visualize both hips so that you can compare one to the other, or the radiologist can. And then the affected hip, we're going to do a lateral or an axiolateral, and this is the Denalius Miller method. This is on page 286, and this is where you're taking a lateral of the affected hip and you're moving the unaffected hip out of the way. So again, the opposite leg, you're flexing that knee and hip. Okay, so you're flexing the opposite leg, the unaffected leg, to try and get that out of the way. The IR is just above the iliac crest so that it's parallel to the femoral neck. Okay, see how this is angled out? So the femoral neck, you're trying to be parallel to the femoral neck, just like when we talked about the hip. You want to make sure the pelvis is not rotated. Make sure their ACES are equidistant from the tabletop. And your central ray is perpendicular to the femoral neck. So it's a horizontal beam coming right in to the femoral neck to project right out onto this IR. Okay, so again, see, you can see this is representing the femoral neck right here, and the IR is perpendicular to that. So if we look at the IR coming like this and the femoral neck like this, then in theory the two are parallel to one another. And when we get the image, and this image has a prosthesis in it, ideally when you do this trauma hip, it might likely not have that unless they have an injury to the prosthetic hip. So if there's a prosthesis, the entire prosthesis has to be captured. All right, and then just a really good image including all of that. But if there was If there's no prosthesis, you still need everything, including acetabulum, femoral head, and then as much of the shaft of the femur as you can get. Right, and that is a Donnellus Miller or an axiolateral hip, and that would be done for trauma. So our routine for pelvis is just an AP. If they're trying to evaluate for developmental dysplasia of the hip in children, you would do an AP pelvis and the bilateral modified Cleaves method. If we're doing the hip, your routine hip would likely include an AP pelvis, an AP of the unilateral hip, and a lateral hip. And if you're doing a trauma hip, then you would likely include an AP pelvis without internally rotating the legs, and then a lateral of the affected hip or the Donnellus Miller method. Okay. If you have any questions or comments or any concerns, we can address those during our live session. Thank you.